Hello, everyone. A very good afternoon. Thank you so much for joining us today. So I'm here to talk about a very interesting topic today. I'm sure every one of us had to encounter it at least once. And before we start, I want you all to take at least 30 seconds and see if you can write down if you have ever had to encounter any type of artifact in your life. Let's see. So I'm sure you all have at least listed one artifact there. So my goal today is to go over some of those basic artifacts we encounter on a daily basis and learn the mechanism and tips on avoiding them. Sadly, I don't have any disclosures. Let's take a quick look at this video. Are all these balls moving in a circle? Let's see. And can you guess which way this idol is moving? So in fact, all these balls are actually moving in a straight line. So I'm trying to make a point that we do make a lot of assumptions about ultrasound. And it's not always clear when it comes to ultrasound artifacts and applications of ultrasound physics and understanding them. So our objectives of our talk today are going to be identifying anatomical pitfalls, which are nothing but benign or anatomical structures which we often encounter, identify some of these ultrasound artifacts, and learn the principles of ultrasound physics behind these artifacts, and learn some of the tips on interpreting and avoiding these artifacts, and finally, some tips and clues on differentiating a real or a true structure from an artifact. I do have an ambitious agenda to cover. Our outline is going to include starting with ultrasound assumptions and points to remember, touching base on some of the anatomical pitfalls, not to forget thinking outside the box, and some basics of 2D color and spectral Doppler artifacts, and some 3D artifacts. So starting off with our ultrasound assumptions and points to remember. So let's start with the assumptions we make in an ultrasound system, right? So we do make a lot of assumptions actually. So we think that sound always travels in a straight line. We also think sound directly travels to the reflector and comes back straight. And we also assume that the structure of the object, whichever it encounters, creates a reflection only once. We also think that sound travels in a soft tissue at exactly 1540 meters per second. And we also think that reflections arise only from the structure's position in the beam's main axis. And we also think that the emergent plane is thin. And we also think that the strength of the reflection related to the characteristics of the tissue creating the reflection. Well, why are we talking about this, right? So very important points to remember. Always apply ultrasound physics when in doubt and think of the basics of an artifact, right? And remember, these artifacts can actually change clinical management and can be very pertinent in critical decisions. You know, very often we read echoes every day, and we do encounter some artifacts and we know can definitely influence clinical management. And it's also important to consider the fact that true anatomy is always visible in all the views. And finally, don't hesitate to admit when not sure. You know, we always approach our multi-modality colleagues for help when we are not sure. And finally, you know, we think about the third dimension, right? And try to visualize every structure in 3D if you can. Well, moving on to some of the basic anatomical pitfalls, right? I tried to make it a little more interesting with some interactive questions, but since we are in a virtual environment, we are going to make it easier. I'm going to start picking whatever favorite I have. I think I'll start off with the right atrium. So let's take a quick look at these videos. I hope they are playing well and you all can see them. So I'm sure you can probably identify all of them here, right? So the first one here is actually a eustachian valve, or the Chiari network, which is a remnant of the right valve of sinus venosus and is frequently associated with PFO. The second one here is actually a prominent kysta terminalis, which is actually basically a ridge which extends from the SVC to the IVC. And the third one here is basically a pacemaker, pacer wire in the right atrium, which is a very frequent finding. Moving on to our left atrium, I'm sure you all want that next. And some of these pitfalls we see in the LA. Let's see if you can guess these. Let's see. So I'm sure all of you got this right. This is actually a prominent Coumadin ridge, which we actually most often see in TEEs, but sometimes can be seen on a transthoracic study also. As we all know, this is a very benign finding. And sometimes we do rarely see some prominent suture lines in patient post-cardiac transplant. The bottom line I'm trying to make here is that it's very important to know relevant clinical history, right? It's important to know that this patient actually had a cardiac transplant in this case. Moving on quickly to our right side. Let's see, we do encounter quite often a lot of things on the right side, right? So this one, I'm pretty sure you all have recognized it already. This is nothing but a dilated coronary sinus, which we usually see in cases with persistent left-sided SVC or elevated RAP. And left-sided SVC, as you know, can be confirmed with a bubble study using a left-sided vein when the coronary sinus actually, highlights first. And then here, let's see if I can play this. And I'm sure you got this one right too. This is actually a prominent RV moderator band, which we can see when the RV is more dilated. And it's in fact nothing but a prominent trabeculation of the RV extending from the base of the anterior pap muscle to the interventricular septum. And it usually contains the right bundle branch. And then and finally, this one here is actually, if you
so, I mean, I think an extra hour.
This is basically an echo-dense tricuspid annulus, which could be either adipose tissue or calcification.
I think a half hour is better because of the schedule.
So moving on to our LV, let's see if you can identify these, right? I'm going to wait a minute for the videos to play.
I can't remember.
5:30, unless we get a patient added on and then they stay a little later. But I think the only problem with call also is that some of us don't.
Sorry, I'm waiting for them to mute the phone.
If you miss the call and you're already home, in traffic, it might take you a long time to turn around and come back. So then the patient is still maybe waiting for a good hour.
I think I probably have to continue talking. So I think let's see if you have identified this, right? So can you guess the odd one here? I'm sure you all guessed it right. The fourth one actually is the image here, which is the odd one, which we know is actually a true apical aneurysm, right? But what's so not abnormal in the others? Let's see. The first video here is actually a false apical tendon, which we know again is a very benign finding, and we often see this. The second one here is actually an LV diverticulum. And the third one here is actually an apically inserted pap muscle. And of course, we see this video with the large true apical aneurysm. Well, it's very important, right, to differentiate an aneurysm versus a pseudoaneurysm versus a diverticulum. So LV aneurysm usually has a wide neck, and we usually see it in the apical or the anterior walls. And LV pseudoaneurysm, on the other hand, has a narrow neck with a wider base and is most often seen in the posterior or inferior walls. LV diverticulum, on the other hand, is actually a benign structure, and it's nothing but an outpouching of the LV that contains all the three myocardial layers and displays normal contraction. So LV diverticula are actually distinguished from the LV aneurysms, which have fibrous walls and exhibit paradoxical motion. And CMR actually is very helpful in identifying that there is no delayed enhancement in the wall of the sac or pericardium in case of a diverticulum. So going back to our original anatomical pitfalls, let's talk about pericardial sinuses, right? So we often see these actually more frequently on TEEs. The transverse sinus is the one which is located between the aorta and the LA actually, and you see here, you can see it in the TE image. And here, the oblique sinus, which is actually more prominently seen, it's behind the left atrial appendage and is seen when there is fluid or fat within the pericardial sinus. And how can we not talk about the valves, right? So here's one, this one is here is interesting actually. So you're probably wondering what's going on, right? So if you pay close attention, there are bright echo densities you see at the edge of the valves, right? And these are nothing but Albini nodules. And you're probably wondering what are those, which are actually nothing but caudal insertion points. And these are actually much more prominent in younger patients. And moving on to our aortic valve, how can we not talk about our famous Lambel's excrescence, right? So these are basically the filiform fronds seen on the aortic valves. And the pathology pictures here confirm the frond-like appearance. And it's, see these pathology pictures, you can see that they're frond-like appearing. And also, it's very important to differentiate them from fibroelastomas, which are in fact more bulkier and have finger-like projections. And sometimes it can be difficult. However, more recent data has shown that these are not as benign as we thought, and actually there have been cases of acute ischemic stroke and acute coronary syndromes in literature, and even the management has been variable, the close follow-up with TEs in asymptomatic patients versus, even putting them on DAPT or anticoagulation in patients with recurrent episodes. So moving on, let's not forget to think outside the box, right? So let's see if you can guess these images. I know our talk is a lot of videos here. I hope they're playing well and you can see them. I'm sure all of you guessed this right. This is nothing but the left brachiocephalic vein we see in the aortic arch or the suprasternal view. The second one here is actually nothing but a video of a loculated ascites. And the third one here is actually a very frequently encountered finding, which is nothing but a shadowing artifact we see from breast implants. And an acute one here is actually the retro left atrial shadow we see quite often, actually. And, you can see it's clearly enhanced after ingestion of a carbonated beverage, and it's nothing but hiatal hernia. Thanks to Clara for this image. So now that we covered most of our essential anatomical pitfalls we encounter on a daily basis, let's solve this quick bonus question. Let's see if you all get this right. So what is the next step you do when you see this image, right? You do nothing, you order a TEE, you start anticoagulation, or you perform additional imaging like biplane and multiplane or color Doppler and add 3D if feasible, or do we skip all these and go straight ahead to a CT? I'm sure you already probably all have got it right? So this is actually a classic example of an off-axis view. And you clearly see that echo density does not exist on the TE image. And as you all pointed out, further assessment with color Doppler and biplane imaging and 3D acquisition can be very helpful in such situations. So moving on to our 2D and color Doppler artifacts. Even before we start, let's start with some basic principles of sound, right? So what happens when a sound encounters an object or strikes a specular interface? So one, either it can get reflected, with the angle of incidence being equal to the angle of reflection, or if actually the angle of incidence is 90 degrees, then it can come straight back up, right? Or what can happen is it can also be transmitted right through the object, depending on the propagation of sound in that particular medium, which is called transmission. Or it can be bent or refracted, and it depends on the speed of the sound in that particular medium which it encounters. Or finally, it can be scattered, right? Scatter, on the other hand, is actually caused by poor reflectors and is increased with increasing frequency of the incident waves. The back scatter is actually the portion which is important for us because that's the one which we use and valuable in imaging, and that's the one which comes back to the transducer. So we're going to quickly talk about some of the basic ultrasound, which are the 2D color Doppler. We are also going to talk a little bit about spectral Doppler artifacts today. We're going to skip contrast artifacts as we just had the iconic talk by Dr. Zogby last week, and we're going to touch a little bit about 3D artifacts. So moving on to our 2D or basic ultrasound artifacts, we have our reverberation, and then we have our comet tail or ring down artifact, and then we have our acoustic shadowing and acoustic enhancement artifact, and then we have our multipath or mirror image artifact, and then we're going to talk about refraction or ghost image artifact, a little bit about side lobe and range ambiguity and beam width artifacts. So, well, I know although these are some fancy names we don't quite often use on a daily basis, it's very important to identify these artifacts and their mechanism, and mainly be able to know the basics on how to avoid these. And that's what we are going to probably talk about today mainly. So let's start with our reverberation artifact. It's also actually known as multipath artifact, and it's nothing but actually production of false echoes due to repeated reflections between two interfaces positioned parallel to the ultrasound beam's main axis, creating multiple equally spaced echoes. I know those are a lot of words. Let's see this, right? So what happens when we transmit the sound? So when we transmit the sound, it first hits the reflector and then bounces back to the transducer, and it creates the first image, right? And then, but if this is a strong reflector, this thing happens again, right? And this time it reaches the transducer again and creates the second image. But remember, the second image it creates is actually farther than the first image, right? And also notice it takes twice as long as the first image and therefore appears deeper. And if this keeps happening, depending on how strong the reflector is, then you can get multiple images right behind them, right? Or right deeper within them. And remember, this one is the first revealed image versus all these are the artifactual or the displayed reverbation artifacts. So what are the key points to remember in this, right? So the artifacts are actually farther than the original reflector. And also remember, most of them are at multiples of original distance between the reflectors. And they typically do not follow anatomical boundaries and usually move in parallel. And this is here for the fellows on listening to our talk today. Remember the word step ladder pattern, right? Every time you get that on board, it is basically a reverberation artifact. And how do you avoid them, right? Essentially, you can change the gain. Sometimes you can alter the imaging planes, and probably the sonographers can chip in even more because they are the ones who actually help us with eliminating them, most of the times. And here you see here are a few examples. This is actually a step ladder artifact, which is created from a strong specular reflector. The second one here, the source is basically the strongly reflecting posterior pericardium. And this creates of a second structure image behind the heart. And this is mainly, if you notice, this is at twice the distance from the transducer as the original reflector. And sometimes these can mimic pleural effusions, right? And this one here sometimes can also, you can create artifactual dissection flaps, again, due to a strongly reflective posterior left atrial wall. And if you pay close attention, these artifacts usually occur again at twice the distance from the transducer as the original reflector. And that's another clue, right? And most of the times, these flaps don't really move along with the, structure itself, right? They don't have that typical independent motion. So moving on, some of the classic variations of reverbation artifact. This one here is actually a comet tail or ring down artifact, which occurs when closely spaced reverberations merge. So what happens is you're having multiple reverberation artifacts here, and they are merging to form a single hyperechoic line. And these are actually more, it frequently happens when there are two or more reflectors in a short distance, like, in prosthetic valves and also aortic plaques, and also behind fluid-filled structures like these sometimes. So the next is our classic acoustic shadowing artifact, right? And we see them as a hypoechoic or anechoic region extending downwards from a structure which is a strong attenuator, right? So if you think about this, and when there is a strong structure causing strong attenuation, sound cannot transmit beyond the strong reflector, and that can cause acoustic shadowing. And it usually occurs at interfaces with very large acoustic mismatch, right? So sound finds it difficult to travel beyond that. Here's a video actually of a bioprosthesis, and you can see that there's a sewing ring here, which is causing this strong, this is the strong reflector, and that is causing the acoustic shadowing here. And this picture, again, you can see both the acoustic shadowing and actually the ring down artifact also related to a injured prosthesis. Acoustic enhancement, on the other hand, this is basically a hyperechoic region. You see beneath the tissue with abnormally low attenuation. And it's actually caused by the low level of attenuation of the beam. So as sound passes through low attenuation and the surrounding structures have high attenuation, you basically get the acoustic enhancement, enhancement artifact. And again, you see here, this is actually an example of a cystic structure causing the acoustic enhancement shadow right behind it. So let's see if we can watch this quick clip.
The Russian card.
I'm sure you're all thinking, what does this have to do with our talk? So that's because the next one is a mirror image artifact. It's actually nothing but a reverberation artifact noted at an angle. So clues is that the artifact is always deeper, and it also moves with the reflector. And also, the fact is that the true reflector and the artifact are at equal distance in this particular artifact. So some of the examples, I think you'll understand better. So, here's a classic parasternal long axis image showing a mirror artifact. which is actually below the pericardium-lung interface. And you see that this is because of you see that there's near duplication of the entire mitral apparatus. And here's another example of where you see a mirror image of the ascending aorta, and even the color appears to have duplicated. But the clue, always remember, the true structure is always the shallow one, right? So the true structure here is this one, and the true structure here is this one. So let's see if you can guess this one now, right? So what do you think this one is? I'll give you some options here. Is this a congenital aortic valve duplication? Is it a pseudoaneurysm? Is it a Gerbode? Or is it a ghost image or refraction? Or
hey, Bindu, you could actually call on somebody if you want. Put them on the spot. Keep this interactive.
Yes.
One of the first-year fellows?
Yeah, if any takers are there.
Possibly side lobe artifact.
Okay. So I'm sure you guessed it, it's an artifact. So you have D or E. Actually, it's a ghost image or a refraction artifact. So it's basically it's the change of sound, direction on passing from one medium to the other, and it actually alters the beam direction, and it causes a side-by-side structure. If you remember your physics experiment, you see when you put a pencil in that, into a water, it causes the side-by-side refraction image. This is also called a ghost image artifact. So let's see if you can guess which one of these is an artifact, right? So I hope you can see these videos. Again, see if there are any takers. Please unmute yourself if you want to talk. Can any of you guess which one is an artifact? Let's see, actually it's none. So case 1 actually here is a case of retained guide wire in the descending aorta. And case B actually is an unfortunate scenario. Believe it or not, it was a pacer was placed in the LV by mistake, actually secondary to access issues. And you can see here that the pacer wire is coursing all the way across the aorta into the LV. Again, this is another important thing, right? So always, when we are talking about artifacts, but remember, there could be something which could be real. So all I'm trying to make a point is don't forget relevant clinical history, right? If you see something suspicious, yes, it could be an artifact, but it could be a real one too. So always, and like I said in the beginning, it's very important because this can change clinical management, depending on what you say. So, always remember, get pertinent, clinical history. If you need additional images, feel free to ask for additional images if you need. And well, Sal, so this is actually the side lobe artifact, so ultrasound beam actually has adjacent or weaker beams that accompany the main beam. And it can create a signal from, so when the beam is going straight through, if anything which encounters the side lobe, which are strong reflectors, they can actually cause another additional image, right? These could be either calcification, it could be foreign material, it could be anything. If it's a strong reflector in an elevational plane, or even, and remember, this reflector could be even out of the plane. It doesn't necessarily have to be in the same plane, where we are sending the image. Like for example, here, right? The defibrillator wire is actually in the RV, but you see here, you feel like as if it's passing across the interventricular septum, but in reality, it's not. It's just actually the linear side lobe artifact, causing this look. And here you see an artifactual, it's actually a flap-like thing, but it's in reality, it's actually a side lobe artifact from a sinotubular junction. So, when you see something like this, again, I'm trying to make a point for the sonographers, change the gain, consider biplane imaging. And I think, biplane is underutilized. If you really, I think it's a very good tool to have, because if you see an image, if you're not sure, and put a biplane on. And the fact that it's on both of the planes, that also helps us in differentiating an artifact from a real structure. And also remember, you also have the additional color, imaging, if you're not totally sure, just add color, focus on that. and ask for help if you need. I mean, you're not totally sure, because, again, at the end of the day, we are trying to help the patient here. So, feel free to and we are all learning here, right? So feel free to add color, add additional imaging if you need, or even call us if you have any questions about these. So, and some of the other, actually, the beam width artifact is nothing but another, example of a side lobe artifact. Here you see this is actually a dilated aorta, and causing this kind of image on the interatrial septum. And remember, like I said, this structure, whichever is causing the artifact, doesn't necessarily have to be in the same plane. It could be in a completely different plane too. So moving on, I have one more question. I hope you're all still focused. So what do you do next when you see this, right? And if I can point what I'm talking about, see that? So do you go for a CMR? Do you go for surgery? Or do you change the depth or alter the transducer location? Or do you do both? Any of the sonographers want to take this? I'm sure you all guessed it. Clara, what do you think?
Well, I will just zoom in the image to see it really clear and change it. We go with 3, change the 3, and
yeah, you're definitely right. And I would also try to go with another window too, right? Because, yes. See that, Clara, right? So I would go with 3 and 4, right? So I'm pretty sure you all guessed this. Yeah, this is definitely, you're not sure what it is. There's some shadowing in the aorta, there's shadowing in the root, but it doesn't kind of look like a typical structure, right? So this again, I mean, I know this is an artifact, but what is this, right? This is actually a range ambiguity artifact. So, look at this. Basically, if you see, there's this floating like image if you see on this slide, right? And if I play the color also, you see that the image is still floating right through the color. So these are basically range ambiguity, they're called range ambiguity. I know these are fancy terms, but what I'm trying to make a point is that, remember, these could happen with different mechanisms. And yes, Clara, you're right. You can change the depth and you can change the transducer location. You can move it either sideways or move up and down one intercostal space. And that can sometimes pick up if it's an artifact or not. So again, some of the highlighted features. So I just want to, kind of summarize what we talked. So real structures usually have distinct edges versus an artifact is more linear and lacks well-demarcated borders, right? And if you think real structures always have independent motion and they concur with the cardiac cycle, versus an artifact doesn't really have an independent motion and moves with the real reflector. And again, real structures are always attached to the other structures and follow anatomical boundaries, versus artifacts do not follow anatomical boundaries, right? They could be randomly located anywhere. And remember, real structures are always consistently seen in multiple views and at multiple imaging depths, versus artifacts are not seen in all the views or not at all the imaging depths. So, bottom line is, so use color Doppler, alter imaging plane and depth, and most importantly, think about logical anatomical relationships, right? And potential explanation for whatever we see. So I'm hoping we are all focused. So moving on to our color Doppler, we have all our 2D artifacts can technically be seen on color Doppler too. And some additional ones include altered color gain, some ghosting artifacts, and aliasing related artifacts, right? So here are a few examples. This one is actually a classic example where you see the color reverberation artifact of color flow in the aorta. This one here is actually a mirror image of the flow in the abdominal aorta, and you see the color is also duplicated. And this one here is an example of a refraction artifact. And here actually is a ghosting artifact, right? We actually see this quite often when there is a strong reflector within the field that causes the dispersion of the color signal, and it causes this bright band of colors through the entire image sector. We actually see these quite often in aortic stenosis too, when there's a lot of calcium in the AV groove and the curtain, you can kind of see that. Let's see if you can identify what's the problem here, right? Feel free to interrupt me if anybody want to take this. What do you think is the problem here? Any of the fellows?
Gain to me.
Absolutely. I think you got that perfectly right. So, right, color gain. If you notice the image on the left, the video here, definitely the color gain is on the low side. Versus here on the right, you see that the color gain is really high, right? Very important, right? We always encounter this, when you're trying to really assess valvular problems. So, and again, I think all the sonographers know this, but, you really have to make sure they are set appropriately at baseline, right? Before even for every patient, I would suggest increase it to a level at which there is background speckling and then decrease from that level to make it optimal on every patient if you can, right? This is again very, pertinent for clinical management. So some other additional artifacts we see, again, sometimes we see these artifacts, which are, it's called the twinkling artifact. It's basically a focus of alternating colors in Doppler signal. And you see there's a bright reflective object and that can sometimes cause it. This is also actually called as a confetti artifact. And then sometimes you see flash artifacts, right? So this is actually a bleeding of color, usually caused by soft tissue motion. And you can differentiate it because you don't see a signal on the spectral Doppler in these cases. And this, again, I think we see this very often too. This is actually an ECOS catheter causing an artifact, right? It's nothing but an electronic noise. And we see that quite often when we do patients, when we image patients with catheters and devices and lines. So switching gears to our spectral Doppler artifacts, we do have aliasing and range ambiguity artifacts. Then we have spectral mirroring. Then we have blooming or blossoming artifact. And then we have wall filter saturation related artifacts, right? So here we have spectral mirroring or crosstalk. It's basically similar to mirror image, which we talked about. You see there is duplication of signals on both the sides of baseline. I know the best expert in this is Dr. Little, who's taught me this, because I know it can actually create directional ambiguity, right? So when you see a signal like this on spectral Doppler, you're not sure where is it coming from, right? You're not sure which one. So remember actually the symmetry, right? Look for the symmetry and remember the brighter signal actually is the real one. And, every time you encounter this, I think, the clue is to look for the brighter signal. And then you also see sometimes blossoming artifact, which is nothing but when the signals are overgained, and you see this, and it's very difficult sometimes to measure the peak velocity, right? Remember, Dr. Zogby was mentioning last week. So especially in patients, when we use contrast, it's hard to kind of really measure the peak. So, the clue is to really avoid those extra signals and at the peak and kind of really choose the brightest spot. And wall filters, actually, we don't see them quite often, but these are actually very important. When we are, we use these to eliminate unwanted signals. And actually, it can also, especially so look at this one, right? So this one on the right is actually with a very high wall filter. You see you have eliminated all those unwanted low velocity signals. And this one actually is a low wall filter, which actually has, you can see all the signals here. So this is actually very important when you're investigating low velocity flows, right? And also like in tissue Doppler, this is also very important sometimes when you really want to get what's from the wall versus not from the tissue. So, and remember, moving on to our 3D, so whatever we discuss can happen on 3D also, right? It can happen with reverberations. You can see shadowing. You can see gain-related artifacts. And we also encounter stitching, dropout, blurring, blooming. I know, again, these are words, but we've seen this like artifacts most of the times. And actually, here are some examples. I hope these videos are playing okay. You can see this one actually is an acoustic enhancement artifact. You see on a 3D, it's from the prosthetic valve. And here you see actually a blooming artifact, which is created by metallic structures and catheters. And you see those fringes extending beyond the borders of the structures. That's basically the blooming artifact. Here, actually, this is actually, we see this very often. It's a dropout artifact. And it's mainly because of the angulation of the beam in relation to the structure, right? And you have to be very careful when you're trying to assess for perforations of the valves, because sometimes when the angulation is not right, it could be just a dropout and not the real structure. And this, again, is a classic stitching artifact. Again, we all know it's because whenever we have irregular heart rate, you can have, problems doing the volume acquisition with multiple cardiac cycles. And finally, this one here is actually a railroad artifact. In this one, when you have larger catheters with wider lumens, they appear as two different linear structures. In fact, it's only one catheter, but because of the wide lumen, sometimes you can see these. So let's see if we have a couple of minutes for some bonus questions. So can you identify this one? Any takers? So is it a VSD? Is it a coronary flow? I'm pretty sure you all guessed it. It's an artifact by now. So it's actually, you know, it's a slice thickness artifact, and it's also called an elevational artifact or elevational resolution artifact. In fact, this is actually a PR jet, you know, because of the imaging plane. We think that the imaging plane is thin, but in fact it's not. So it's the PR jet from a different elevation we are catching on this view. Very important, right? Sometimes we get confused it with the VSD. Let's see if you can guess this one. Why don't we see the ball and cage prosthesis, right? Has it really embolized? Has it shrunk over time? Or is it because of slow and smooth motion, or it's because of our transmit power? So actually, this is, you know, because of the slow and smooth motion, right? And it's also called a velocity error artifact. In simple terms, what happens is when you transmit sound, you know, the ball actually has a different, you know, tissue characteristics, right, than the surrounding, structures. So what happens is it takes much more longer to return to the transducer, and that's why the shape of the ball can be confused. And here, this again actually is a very famous one. I'm sure you have recognized this before. You've seen this before. This is not an artifact, but it's actually residual native leaflets, right? Sometimes we see this sometimes as you have a bioprosthesis, but then they left the native leaflets. And this is nothing but the second image here, or the valve which is moving with the valve, is actually the native leaflets of the, you know, original mitral valve. So to finish with our conclusions, always remember common sources of error and misinterpretation, and true anatomy is always visible, and try to explain based on principles of applied physics. And finally, we need to have some knowledge on key points on how to avoid these artifacts, right? Thank you all for your attention. So remember, something fishy, consider an artifact. Hope you're all not feeling like this, because we still have Mohammed taking us on a tour with CT and CMR World of Artifacts. And if you all don't mind, we'll reserve the questions to the end if we can. Thank you so much.
Well, Bindu, thank you so much indeed. This is an outstanding lecture. And let me move on to setting up the screen. Can you guys see this? Okay.
Yes, Mohammed.
Okay, excellent. Well, I mean, Bindu, thank you so much indeed. And honestly speaking, artifacts is a hot topic for the board. So I strongly encourage fellows who are taking whether the ECHO or the CT or the MR board to focus on these, as they're also low-hanging fruits and a hot topic. So my job in the next 20 minutes.
Mohammed, can you swap displays so that we get presentation mode?
Oh, sorry. Is that better?
Yeah, that's good.
Okay. So in the next 20 minutes, we're going to be talking about cardiac CT and cardiac MRI artifact. And just for the sake of it, none of these circles are moving. They're all stationary. And that's really what we're going to try to focus on. So if we start up with cardiac CT, I guess we really need to understand that motion or blurring artifact is really the most common type of artifact that we encounter during cardiac CT imaging. And the motion can occur either because of cardiac motion or coronary arteries, which especially the right coronary artery has the highest susceptibility to motion artifact. These can occur because of irregular heart rates in the setting of tachycardia and or arrhythmia. The second type of artifact that we see for motion if patients breathe in during the scan. So that's why all these acquisitions, whether cardiac CT or cardiac MR, they do require patients to hold their breath for certain periods of time. Now, the images in cardiac CT, we try to acquire them during the least motion. And this is typically during diastasis due to limited temporal resolution with the CT scanners. And this is the reason why we, most of the time, use beta blockers in order to lower the rate and prolong the diastolic period time. The essence of gating in cardiac CT, and the most common mode is the prospective EKG gating, What we mean by that is that we tell the scanner where the R waves are, and what it does, it's actually looking at that period when we want to turn the tube voltage on and acquire our images. And during that first RR interval, it's going to acquire a segment of the data, and then the table is going to move on, and then the tube is going to be on and acquiring a second set of images, and then moving on and forward. And this usually averages between 4 to 5 cardiac cycles. So the way that the data is acquired in cardiac CT, it depends on the number of detectors that you have in the scanners. Nowadays, the most commonly used scanner is 64 slice, and that's the one that's the minimum required for cardiac CT images. But as we can see, during the first RR interval, I'm acquiring 3 centimeter worth of data. During the second RR interval, I'm stitching another 3 centimeter on top of the first image. And then during the third RR interval, now I have completed my entire cardiac acquisition. So here it roughly took like close to 3 heartbeats. So coronary motion is actually important. And as you can see in this diagram, velocity on the y-axis and phase on the x-axis is that the right coronary artery in red, it has the highest coronary motion. And the reason why we want to try to image those, we want to try to image the arteries when they are motionless. And typically, the least motion they are going to be is during diastole, which is 70 to 80% phase of the RR interval, as we can see here. But also in people who have fast heart rates, like atrial fibrillation or tachycardia, the period between 30 to 40% of the RR interval, which usually corresponds to the isovolemic relaxation time, is another good timing in order to image those coronary arteries. So how do I get a motionless right coronary artery on cardiac CT? And how does a right coronary artery motion artifact looks like? So if you focus on this axial images of the heart, I can see the right coronary artery, and there is what appears to be like a black halo surrounding this right coronary artery. Sometimes people call it winging appearance. And this is basically how you can tell that this coronary artery has severe motion artifact, which really renders this segment uninterpretable. So if we can see here, the images are acquired, and this is a curved planar reformat of the right coronary artery. And I can see this proximal to mid right coronary artery is not interpretable because I've acquired data during the atrial kick, which is 450 milliseconds here after the RR interval, so way after the T wave. However, if I choose a different phase, and in this case, I went to a 350 milliseconds, so somewhere after the T wave, somewhere after end systole, and now my proximal to mid, same patient, my proximal to mid right coronary artery has beautiful contrast enhancement, and it appears motionless, and I'm able to interpret this segment. Here's another image of a motion artifact in the right coronary artery where you see all this black halo surrounding the artery. Here's how it looks like on the volume rendered image. It almost looks like the artery is out of phase from the proximal to the mid segment. So this is really what RCA motion artifact looks like. And how does cardiac motion artifact occurs? It probably occurs in the setting of arrhythmia. And I want you to notice here is how there's a double shadowing in that posterior left atrial wall. Again, we're looking at axial slices. Look how there's shadowing here, like a double shadow in the left atrium and the septum and also in the posterior wall. So here, how does the sagittal and the coronal reorientation? Here's the sagittal reorientation. We can see there's a double line or a double border on the left atrium, on the aortic wall, on the RV. Again, also here on the coronal, I do see this double shadows. And the reason why this patient has had so much cardiac motion artifact is the fact that the patient was an atrial flutter, as we can see here, and the data was acquired sometime during systole, because there is so much variation in the diastolic period because there is so much atrial activity compared to ventricular activity in this case. Now, how does step artifact? So another term for artifacts is the step artifact, and this usually is an inherent machine-related artifact, which happens because of misregistration. So if you all remember, the way we acquire those data is that we stitch those data if they are being acquired in a sequential mode, and then after this stitching, the machine has to register all the data together. And what we can see here in this right coronary artery is that there's almost what appears to be a break in line, or the artery almost jumps out of place. So this is how this artery looks like, the proximal segment, and then after that, the whole artery. And you can see the step artifact looking here on the curved planar reformat. The whole artery has broken and it has jumped out of phase. Here's the proximal, here's the mid segment, So this is what a step artifact looks like. Here's another example with severe multiple step artifacts, as we can see in those lines across the cardiac chambers, the aorta, the pulmonary artery, the descending aorta. So really the solution for these is we need to use more of the wide coverage detectors. So a scanner by which with one gantry rotation, I can cover the whole 15 centimeter field of view, which is the heart. And nowadays, different vendors do have this, including the Toshiba, Toshiba along with the GE. Or you can use what the Siemens has is the high pitch spiral acquisition mode. So this is an axial or a spiral acquisition scan, but it really eliminates significantly this misregistration artifact, because now you have two sources of the camera head by which you can interpolate those image data. Now, how does breathing motion artifact looks like on CT? So typically what we look at the break in line in the sternum. And this is a very favorite board question on the CT board. So we can see this break in line in the sternum, meaning that the patient, they took a breath in during the scanning. And unfortunately, this has rendered the proximal left anterior descending uninterpretable because of motion artifact, where I can see the distal segment very well, but I have blurriness in this proximal segment. So it's very important, and our sonographer, our techs, they do a great job practice breath holding with patients. And then sometimes you need to kind of resort to this single beat acquisition, like what the GE and the Toshiba has, or the high pitch scanning with Siemens, because these are the very fast scanning modes, and at the same time do not require the patient to hold their breath for a long period of time. Here's another severe ladder step artifact in the setting of breathing motion, where we can see multiple break lines across the sternum and also across the cardiac chambers. Now, streak artifacts is basically, another word is metal artifacts. And the reason why they occur, because the energy from the CT photons, they are gonna be not all uniform. Some of them are gonna be high energy, some of them are gonna be low energy. So when the low energy X-rays get attenuated, the resultant beam appears to be more hardened, and it's gonna have a higher average attenuation value. So we see that with metallic objects, we see that in calcification, and with regions with high contrast density, when the contrast goes into the superior vena cava, it can cause some artifact. Again, a lot of nomenclature, beam hardening, blooming, but let's take a look on how these look like. So here's a beam hardening artifact in a patient who has a proximal stent in the left anterior descending artery. And what we see is that the center of the stent, it appears to be very low attenuation because of all those energy beams going in. Some of them are being canceled, but what it's causing this weighted average of X-ray hitting the stent to cause more hardening of those X-rays. That's why this area appears to be dark compared to another segment. So the way we resolve that on our cardiac CT scanners is using different reconstruction filters or kernel filters. And the sharper the filters are, the less attenuation and the less beam hardening artifact I'm gonna see. And now I can see with confidence the center of the stent, and it's no longer artifactual as in the previous image. Here's another example for streak artifacts in a patient who has a mechanical mitral valve. We see as those X-ray energies hit those metallic struts, how you have this black halo coming around here and here. And again, these are streak artifacts in the setting of pacemaker wire. So we can see here the pacemaker lead in the right atrium, and we see so much of streak artifacts, and almost some of them appear to have like a starry sky appearance. And here's another coronary sinus lead with also the black halo causing those streak artifacts in this case. Here's a non-contrast image, and here's with contrast how those artifacts will look like. Looks about the same. Now, blooming artifact is kind of the common artifact that we see in the setting of excessive calcification. So here's an LAD territory where there is truckload of calcium. And everyone who reads cardiac CT knows this is the cardiac CT's nightmare. And it's the Achilles heel of CT imaging, because with so much calcium within the coronary arteries, it actually blooms over the lumen, and I'm not able to tell how accurately stenosed this vessel is. So we can see here on this curved planar reformat how the short axis images, you have this eccentric calcium, and I cannot see on these images how much of stenosis is this calcium causing. Now, what is the underlying mechanism for this blooming artifact? In essence, it's a partial volume averaging. So what does that mean? So tissues which has different characteristics or properties, they are contained within the same image voxel. But the weighted average of these attenuation, they're basically gonna create some sort of a different weighted density if we look at it. So look at these boxes here in each voxel. So you have the orange boxes, you have the dark purple boxes, and if I have something that has a mixed tissue attenuation, say for example calcium, when I look at it on the z-axis, now this whole area is no longer either orange or dark purple, it's actually light purple. So unfortunately, this area is actually blooming. It's actually taking over the standard pixel size of a standard tissue. And that's exactly what calcium does for a pixel. Imagine this is a calcified plaque. It's going to take over the weighted average of all those attenuation. And unfortunately, it's going to cause this density that's going to take over other pixel sizes. Now, last but not least on CT, before we move on to CMR, is the CT noise, with radiology described as a mottling appearance of the cardiac CT. So we can see here how so much noise by which we see those speckles within this cardiac CT acquisition. And this is almost always is due to low photon counts, because CT is a transmission map, meaning that the photons, they have to penetrate through those cardiac structures in order to produce an image by a way of different attenuation. Here's another image where I have very poor contrast enhancement compared to this image and a lot of noise, which is all those speckles. And really the solution behind that, which we see in obese people, is you need to increase the current or the tube voltage, bearing in mind that this will increase your radiation dose. Other thing you can also do is increase the slice thickness or use softer filters so that you smoothen up those images. So moving next to cardiac MR, and cardiac MR has the same mechanism by which these are ECG-gated and breath-holding examination that we can create any image within the heart. We can create short-axis planes, we can create long-axis planes, and really kind of the way we summarize the CMR artifacts are actually looking at motion, whether the patient moved during the CMR acquisition or whether it is respiratory motion, so by which the patient did not hold their breath adequately, which is a very common cause of artifact. Gating artifact from ECG, physiologic artifact, hardware, and then we're going to go over some other different artifacts with examples. But for the sake of time, really kind of the main references for this CMR artifacts, because there are so many of them and there's a lot of physics behind them, but really these two articles appears to be very highly preferable if someone wants to go back and expand on those. So here's an example on a sagittal short axis view of the heart by which the patient did not hold their breath. And the way I can tell that, I have blurriness within the heart, but also I have blurriness within the abdominal organs. So unfortunately, this patient during the cine acquisition was not able to hold their breath long enough. So what are some simple solutions we can do? We can try to reduce the K-space lines. We can try to increase the data lines per cardiac cycle. This will affect your signal to noise ratio. Or you can reserve to a real-time acquisition by which the patient can breathe freely, and I'm just going to acquire data with a free breathing mode. Now, gating artifact, the way that MRI images are reconstructed is basically they are acquired in a segmented fashion over multiple cardiac cycles. And most commonly we use retrospective gating, but sometimes we have to use prospective gating. So what happens is that I have here bins between RR interval, and I'm actually dividing those to 15 phases of cardiac cycles. And with every phase, I am filling K-space lines. Here, it looks like I'm filling 4 with every phase. And with that, what we can see in a gated acquisition is that I'm going back retrospectively, and I'm filling those data lines in order to acquire images both in systole and in diastole. And the way that it's being done is retrospective according to this image. So retrospective, we're acquiring all the data behind the R waves and after, so systole and diastole. Prospective, I tell the machine that the R wave is here, and I'm going to acquire the data after an interval delay, and this is going to be my data acquisition prospectively after every QRS, which is going to trigger the acquisition. So here's an example of an arrhythmia artifact by which I see a lot of motion within the heart. And unfortunately, this is in the setting of PVCs and or AFib, where we see this cine acquisition is no longer crispy clean, and it's basically more blurry. How do we get along with those arrhythmias artifacts or AFibs? If I use retrospective gating, I got a variable RR interval. I have variable periods in diastole to image. While if I use a prospective gating by which I'm trying to omit this period in diastole and acquire most of my images to basically occur in systole and IVRT, then here I'm going to have much better signal to noise ratio compared to the retrospective, but I may not will have end diastole in those images. So it's good for systolic function assessment because I do have end systole with prospective gating. Now let's talk about phase wrap or aliasing artifact. So what happens is that when I have a smaller field of view and parts of the body that are outside the field of view are wrapped around to the opposite side of the image, this is exactly what a phase wrap artifact occurs. And the solution for that is you have to increase the field of view, or sometimes because it occurs in the phase encoding direction, you need to phase oversample. So here's an RV3 chamber view, and I can see this fat along with the arm here seems to be wrapping over the image. And this is basically creating a phase wrap artifact, in this case of an RV3 chamber view cine. Now, if the wrap artifact can also occur in late gadolinium enhancement images. So you can see this wrap here that's starting to overlay my left LGE images. And what it's causing here in this image, it is causing an artifact on that anteroseptal wall, and it's almost causing a false positive delayed enhancement. The rest of the myocardium is null, but this area, unfortunately, because it's subjected to this phase wrap artifact, it's creating a false positive. So artifacts are important to recognize because it can lead to misinterpretation, as we see in this image here. Now, the steady state free precession, which is really the power horse of cardiac imaging, is susceptible to a lot of banding artifacts. And this occurs because of dephasing of those protons or spins. And obviously, it's more common with a 3 Tesla scanner than 1.5, because obviously I have more energy and a stronger magnetic field. Areas of significant inhomogeneity can also cause those artifacts to be worse. And usually we try to correct them by lowering our TR time and also using shimming coil over the region of interest. So we can see here the dark banding artifacts. We can see those multiple bands within this image. And these are usually occurs in stationary tissues, like here in the fat, in the abdominal fat, whenever I have high signal tissues near the edge of the field of view. So this is an SSFP cine sequence showing dark banding artifacts. Now, flow artifact can also, especially in the setting of, sorry, I'm just trying to see if I can get this to move. So especially in the setting of turbulence flow. So SSFP is also notorious for that, where we can see here a bicuspid aortic valve, and there is a big band, almost like a pulsatile flow artifact occurring from this image. Well, if I switch to a spoiled gradient echo, I can dramatically improve this image acquisition. And let me try to move on to this here. Well, you see here, I no longer see this flow artifact occurring in this spoiled gradient echo because I took away of that SSFP flow artifact. Now, signal loss artifact can also occur. So here's a high resolution image across the aortic valve, and I can see the signal loss occurring from the pulmonic vein. And this is also occurring in an SSFP sequence, and it's predominantly flow related in this case. Now, the 3 Tesla artifact, again, it's going to cause more of this dark banding artifact. And we see it also here on the descending aorta. And this is, again, more susceptible with SSFP sequence because of the use of the higher magnetic field strength. A first pass perfusion artifact, which we call the dark rim or the Gibbs artifact. And what we see is this 1 pixel intensity subendocardial defect that usually it occurs because of multiple factors. The most common one is basically the interplay of the contrast, the high contrast medium within the blood and the myocardium. And it has to do with the Fourier transformation by which truncation can occur at those different frequencies. Some other theories could be related to cardiac motion or undersampling. But what we can see here is this artifact usually lasts, it's very short lasting, only 3 to 5 cardiac cycles. Compare this to this dense subendocardial perfusion defect in the inferolateral wall. So this one here is artifact while this one here is unlikely to be artifact because it's dense and it's basically lasting and persisting more in cardiac cycles. But do not misinterpret these as ischemia in the anterior and the anteroseptum inferoseptal wall. Here's an example of a T2 star image by which this patient has ion overload of the liver. And the nature of this image, which is a gradient echo, unfortunately, ion causes so much magnetic field inhomogeneity. So when I'm trying to get a T2 star of the heart, I see all this darkness and off resonance artifact. And this is, in this case, it's overlying my heart. Why? Because ion has created so much magnetic field inhomogeneity. Here's a metal artifact that occurs in a patient who has sternotomy wires, and this is what metal artifacts look like. Here's a pacemaker artifact in a patient who has a generator, and also appears to be alteration of the radio frequency signal. There might be something interfering during the time of this acquisition because of all this white bands. There might be some RF interference occurring at the time of this image acquisition. Late gadolinium enhancement artifact in the next few slides. Basically, ghosting artifact is one of them. We can see a ghosting artifact here and here. And usually when they are due to breath holding, the patient does not hold their breath. Usually we see ghosting from adipose tissue, as we see here and we see here. And this is unlike arrhythmia artifact, which basically causes artifact within the myocardial cavity, as we see here in this image. Now, last but not least, we do see sometimes a improper nulling of the myocardium, which is a LGE or a scar imaging sequence. So what we see here, if I use a short T1 time, but it's causing the myocardium not to reach the zero nulling point, and that's why it appears to be a little bit of a brighter signal intensity. Well, if I use the proper inversion time, and I'm making sure that I'm imaging at the zero crossing of the normal myocardium, I should have a normal homogeneous appearing viable myocardium, which is black, meaning that the myocardium has reached the nulling point, unlike this one here, where I fell short of my TI time or inversion time and caused this myocardium not to be nulled properly. The chemical shift artifact, basically it occurs in the interface between water and fat because they do process at different frequencies, and this creates almost 3.5 particles per million. So usually in a 1.5 Tesla, this will create a frequency shift of 210 megahertz. And this basically leads to a misregistration artifact in the frequency encoding direction. And this basically leads to signal loss. As we can see here on this scar image, I have the RV wall, I have a pericardial effusion, and I have an epicardial fat. And I do have a signal loss between the border of the effusion and the fat in this case. We also see it here between the epicardial fat. I have this dark rim between the myocardium and the epicardial fat, also in the setting of chemical shift artifact. So really, to conclude, everyone, knowledge about appearances of artifact is really essential to avoid misinterpretation and be aware of what available methods we have for eliminating artifacts and or lessening their severity. Grateful that you listened, and thank you all for your attention, and me and Bindu are happy to take any questions.
And I do want to take this opportunity to thank all our sonographers and technicians for the amazing amount of work you all do. And I really thank you for all you do. Any questions? I guess we'll end this session here then. Thank you all for joining us today. And thank you, Mohammed, for such an amazing presentation.
Thank you, Bindu, and you all stay safe and take good care.
Mm-hmm.